All righty. Thank you for joining us tonight for Let's Talk Ethics Confidentiality for Medical Interpreters. So my name is Kelly Gretsch. I am a certified medical interpreter. I'm a Spanish interpreter, and I'm the co-founder of interpretmed.com. So this presentation is brought to you by interpretmed.com, which is a practice community for medical interpreters. We have tons of really awesome practice materials. And this month, we're actually doing a written exam study guide. So if you are trying to pass the CCHI exam, the NBCMI exam, we have lots of really engaging material, including a bunch of things to practice with the ethics of medical interpretation. So today, what we're going to start off with, well, first we're going to talk about what we're going to do today. So here's what we're going to do. So we're actually going to compare and contrast what the Ncihc, the IMIA, and the CHIA codes of ethics say about confidentiality. So recently I've become a little bit of an ethics nerd. I'm not going to lie. And a big reason for that is, well, I started actually comparing and contrasting the different three main, I call them the big three, codes of ethics for medical interpretation from the Ncih, the IMIA, and CHIA. And there are actually some key differences and, of course, similarities between these codes of ethics, but really drilling down and comparing and contrasting has helped me to understand our ethics from a different point of view and really understand them more thoroughly. So now I can engage in more ethical medical interpreting. So we're going to compare specifically what these codes of ethics have said about confidentiality. Next up, we're also going to explain our legal obligations to confidentiality. Now, I am based in Richmond, Virginia. Ncihc, who is our founder, is based in the Dominican Republic, but Ncihc does a lot of remote medical interpretation for the United States. So I'm curious here, is anyone here not from the United States, not interpreting remotely for medical interpretation in the United States? If you are, so if you are interpreting from another country for another country, if you wouldn't mind dropping your country in the chat. I'm expecting some folks from potentially New Zealand and Australia based on something that was shared earlier today. From the UK, oh, that's awesome. So what we will be talking about legally from Egypt for US and UK clients, okay, that can be a little bit challenging interpreting for different countries because you have to be familiar with some of the laws and healthcare regulations in those different countries. Because I know when I was doing remote interpretation, even here in the United States, I had to be familiar with different states' laws. And oh, from Korea. Oh my goodness. Oh man, we have people from all over the world. That's awesome. So interpreting in different areas, in different countries, even in different states within the United States can pose some different legal challenges. Of course, the differences are going to be bigger among countries. So what we will be going over today will be US-centric in terms of the legal portion. However, I definitely invite you, when we are talking about laws and regulations, to kind of keep in mind and maybe compare and contrast some of the laws and regulations in your own country, in your own state, or in your own province or locality, and kind of contrast that with the US laws or main big law we'll be going over today. So we're going to be talking about our legal obligations to confidentiality, of course, like I said, US-centric. We're also going to kind of analyze how our legal and ethical responsibilities to confidentiality may overlap. So we're going to be doing some comparing, some contrasting between codes of ethics and standards of practice. We're also going to be comparing and contrasting our ethical versus our legal responsibilities to confidentiality. And lastly, this is kind of key here, we're going to identify if and when confidentiality can be broken in the context of our codes of ethics, and in the context of legal stuff, all that meaty legal stuff. So to start off with, the three main codes of ethics I'll be touching on today, I'll just list them off very quickly. So we're going to be talking about the Ncihc Code of Ethics, the IMIA Code of Ethics, and the Ncihc Code of Ethics, the California Healthcare Interpreters Association Code of Ethics and Standards of Practice. The reason why I'm going over these three is because I'm based in the United States. And in the United States, the two main certifying bodies for medical interpreters are the NBCMI, the National Board of Certification for Medical Interpreters, and CCHI, the Certification Commission for Healthcare Interpreters. Say that 5 times fast. So the reason why I'm mentioning this is because these two organizations, the NBCMI and the CCHI, ask for certified medical interpreters. If you're looking to become certified, be familiar with all 3 of these codes of ethics and standards of practice. So the main code of ethics I do see being taught to medical interpreters, especially in the United States, is the Ncihc Code of Ethics for interpreters in healthcare. And it says the following: the interpreter treats as confidential within the treating team all information learned in the performance of the professional duties while observing relevant requirements regarding disclosure. So this comes directly from the Ncihc Code of Ethics. There are 9 ethical tenets, so they have 9 of them. But if you actually read the entire document, now I'm a nerd, I have a big binder of all the codes of ethics and standards of practice. So I've read them thoroughly many times. There's actually a section in the Ncihc Code of Ethics that's called Commentary on the Principles in the National Code of Ethics for Interpreters in Healthcare. And there's 3 pages of discussion about confidentiality. 3 whole pages. So I'm obviously not going to go ahead and copy and paste those here because we could spend a whole 2 hours on that probably. I can make it happen. But I will be pulling in some of the points that they mention throughout the discussion today. So furthermore, so that's just the Code of Ethics for Interpreters in Healthcare from the Ncihc. We also have the Ncihc Standards of Practice. So in the Ncihc Standards of Practice, we have this objective of confidentiality. And this objective states that we're supposed to honor the private and personal nature of the healthcare interaction and maintain trust among all parties. So that's the objective, but then we have the 2 standards that come right after it. So the 2 standards say, first one is standard 7, which says the interpreter maintains confidentiality and does not disclose information outside the treating team, except with the patient's consent or if required by law. So the example here is that an interpreter does not discuss a patient's case with family or community members without the patient's consent. Next up, standard 8 says the interpreter protects written patient information in his or her possession. So the example here is the interpreter does not leave notes on an interpreting session in public view. So this doesn't include anything about digital security or anything along those lines. So perhaps we will discuss that some other time because boy, do we have a lot of things to go through. But at the very least here, we are talking about written information and oral information with the expectation that information in general will be kept confidential. So that's the gist of the Ncihc Code of Ethics and their standards of practice. Now, I will say that originally when I was going to do this, I thought, oh, this is easy. There's just a 1 line in the 3 codes of ethics and we'll talk about those. No. It was way more complicated and way more in-depth than I originally anticipated. So that's why this section is a little bit longer than I was anticipating it was going to be. But don't worry, we're going to breeze right through them. So the IMIA Code of Ethics from the International Medical Interpreters Association, they actually authored the first Code of Ethics on medical interpreting. The Code of Ethics for Medical Interpreters, such an original name. The very first of their 12 ethical principles states simply, interpreters will maintain confidentiality of all assignment-related information. But their standards of practice goes over some more stuff. Goes over interpreter duties. So the interpreter duties are interpretation, cultural interface, ethical behavior. So that's where confidentiality comes in, into ethical behavior. So on this one, we're actually given a scale of 1 to 5. showing whether whether you have mastery of these skills or whether you don't. So there's 4 skills. So we have duty C, ethical behavior, and the first one of these, C1, is maintain confidentiality. So we have indicators of mastery, indicating that you've mastered the skill, that you're good at it. And then we have indicators of lack of mastery. I'm just going to give you the indicators of mastery because I feel like it's redundant if we do both of them. So the first one is can explain the boundaries and meaning of confidentiality and its implication and consequences. Obviously, if you lack mastery in this skill, you can't do this thing. So now we need to explain confidentiality, not just enforce it, which kind of makes sense. We should know what it is before we're actually respecting it or protecting it. Next up, knows and maintains the clinical parameters of information sharing in keeping with the policies and procedures of the institution and/or team. Knows how to respond to questions dealing with confidential matters that may be brought up in the community or healthcare setting. My favorite example of this is you're in the grocery store. You're with your husband or your significant other or your girlfriend, whoever. And all of a sudden a person approaches you and they say, in your target language, in my case, that would be Spanish, "Oh, hey, don't I know you from somewhere?" You have to know how to respond to situations like this. So in that particular case, I wouldn't acknowledge that I know that person from anywhere. I might respond to them in their language, or the language that I also speak, which is Spanish. And then I might say, "I'm sorry, I think you might have me confused with someone else." Because if I acknowledge that I know them then and there, then that's actually a breach of confidentiality because I'm acknowledging that, hey, I've probably interpreted for you before. That's probably where I know you. So you have to wait until the patient or that person who you've interpreted for before to kind of say, "Oh yeah, aren't you that interpreter who interpreted for me at City Hospital?" And then that's when you can say, "Oh, I'm sorry, I interpret for so many different people. Hey, how are you?" You don't want to say to your significant other, "Oh yeah, I've interpreted for that person before," because that's actually a breach of confidentiality, not just ethically, but even legally. So got to be careful with that. But that's the kind of example that I like to give with that, and we can get into that in a little bit more detail later. Next indication of mastery, according to IMIA, is if we are privy to information regarding suicidal or homicidal intents, child abuse, or domestic violence, we act on the obligation to transmit such information in keeping with institutional policies, interpreting standards of practice, the code of ethics, and the law. So these are kind of special situations that we need to be mindful of. Because even in certain states in the United States, interpreters can be considered what are called mandatory reporters of abuse, of things like this. So we need to be mindful of this. And lastly, we have CHIA, or the California Healthcare Interpreting Association. So their ethical principles for healthcare interpreters, these are actually embedded in their standards of practice. Their standards of practice includes a whole bunch of stuff, including stuff about the roles of the medical interpreter. So it states simply, interpreters treat all information learned during the interpreting as confidential. Now, we do have some performance measures that are listed under that. I like this stuff because it kind of gives us more detail. It kind of gives us a fuller picture. So the performance measures say that the medical interpreter should advise all parties that they will respect the confidentiality of the patient-provider interaction, and, when applicable, to explain to the patient what confidentiality means in the healthcare setting. So this might be something that we would include in our pre-session. I often do this with providers who like to have extraneous conversations in the room. I'm an in-person interpreter, so I interpret for a lot of the same patients over and over and over again, in the same practices over and over and over again. So if I have the same problem with the same provider over and over and over again, where they're not really having these side conversations outside the room, having these side conversations in front of the patient, and might be assuming that I might not interpret them, I might just remind them. Switch to third person and remind the provider and then interpret that to the patient, or just include it in my pre-session to begin with. Advise all parties in the interpreting session to refrain from saying anything they do not wish to be interpreted. Again, perhaps pre-session material, maybe a third person interjection material. The reason why session is italicized and bolded is because here in their standards of practice and codes of ethics, they actually define what session means. Another thing we should be doing, according to Ncihc, is declining to convey to providers any information about patient gained in a community context. It says this is more likely to occur in linguistic communities that are demographically small. However, as an in-person interpreter here in Richmond, Virginia, I'd say we live in maybe a mid-sized city. I interpret for a lot of the same patients. I know a lot of the interpreters who are friends of mine, they likely interpret for a lot of the same patients. So even though our linguistic community, Spanish is a pretty big language, isn't really demographically small, there's still a probability that if I say something to another medical interpreter in my area, like, oh, I interpreted for this patient yesterday who had rare genetic condition. How many people in my area, they know what my target language is, have that rare genetic condition? They might be able to figure out from that who I'm talking about. And that is breaking confidentiality. So be careful. And then this actually repeats exactly what the IMIA said. So considering the IMIA Code of Ethics came first, and the standards of practice, I believe, came before the Ncihc Code of Ethics, they probably kind of copied this from that, but they add something. In cases where interpreters are privy to information regarding suicidal/homicidal intent, child/senior abuse. So I believe in the other one, it only says child abuse. Here it says child or senior abuse or domestic violence. Interpreters act on the moral, if not legal, obligation to transmit such information to the provider in keeping with institutional policies, interpreting standards of practice, and code of ethics and the law. So we have a couple of little differences here, but ultimately the spirit of the message here is the same. And then lastly, this is interesting, decline to convey to patient any personal information about the provider. So now that I've talked at you for a minute, we are actually, so I apologize if any of you are not particularly social, but we're actually going to be doing activities in breakout rooms here. So I give you this example here, not for you to spot 7 differences in these pictures, because honestly, this one's kind of hard. But this is going to be similar to the activity that we're about to do. I had these things in like little magazines when I was a kid where you define the 7 differences between the 2 pictures. But what we're going to be doing is actually going between these 3 codes of ethics and finding as many differences as we can. So I know that's going to be hard unless you have a document, right? So I have gone ahead and made a document in Google Drive that we can reference for this. So I've pasted this in the chat. This document has all of the slides in it, not all of them. Basically the spoiler-free slides, because I don't want to give you all the information, right? And all of the 3 codes of ethics. So everything we just went over is actually available in this document. Let me see here. I think we have enough participants to do, we'll do 3 breakout rooms. And I'd like you with your group to have a kind of discussion and kind of look over the codes of ethics that I've provided for you in the document and try and find as many differences as you can. It's really easy to find similarities. You probably come up with way too many similarities. So the differences are key here. And this will really help you understand, well, what we have to gain from each code of ethics. So I'm going to go ahead first, before we go to the breakout rooms, I want to make sure that no one has any questions about what we've just gone over. Feel free to ask me all the questions in the world. Okay, well, I'm going to go ahead and we'll do 3 breakout rooms. And
I'm sorry, I just want to make sure that I have the right document open. Is it the slides or is it different?
yes, it will be the slides. But if you proceed from the first slide, you should then have the 3 codes of ethics with all that handy information on the slides. That way you don't have to go thumbing through all 3 codes of ethics, which would be really hard.
Right, thank you.
Of course. All righty. So again, that link is in the chat. Definitely let me know if you cannot access that document. I will be here in the main session. And Ncihc and I will be answering some questions for, I believe, folks on Facebook, right, Ncihc?
Yes, that's right.
All righty. So I'm creating the breakout rooms now. I'll give you about 10 minutes, okay? Okay, folks are starting to go to their breakout rooms. I just want to make sure we're not going to have any rooms with 1 person in them.
Yeah. No, I think it's good.
Okie dokie. I see room 3 only. Oh, wait, no, we got 2 people in room 3. As long as we have 2 people, we're good, right?
Yeah. Yeah, but I think all groups have at least 3 people.
Beautiful. All righty.
Elizabeth just joined. Hi, Elizabeth.
Hi, Elizabeth.
Hello.
It's not just us 2, I promise. We're actually in breakout rooms right now discussing the 3 codes of ethics and what they say about confidentiality. So, would you like to go to a breakout room or would you like to hang out with us while we answer some questions on Facebook? I know it's a lot of pressure.
I just switched my Facebook off because I was in Facebook and I'm here. So I'll stay here.
Okay. So what's going on, Ncihc?
Well, on Facebook, we only have Nesrim said hi.
Hi,
so,
Nesrim.
Hi, Nesrim. Hi. So there are no questions on Facebook right now, but I actually want to, I told you that I published an ethical scenario, but it's not so much related to confidentiality, but there were some interesting comments and I want to read them just for the people who cannot make it to Zoom. Okay, so I shared a ethical scenario, and let me see if I can retrieve it from the group because there are so many things in the group. Just wait a second in here.
It's fine. I'm just fixing my hair. I've been trying to go to the salon and none of the salons are taking appointments right now.
Oh, wow.
Yeah, I want to get my hair cut off, but.
I was confused. I didn't know if I should have joined the Zoom or stay in Facebook. I see it's only 3 of us here. So
we are in breakout rooms right now, Elizabeth. So on room 1, we have 5 people. I mean 4. Okay. We're like 15 people. So they are. If you want to, you can join them, and they are discussing with a slide.
Oh, okay. Oh, okay. Thank you. Yes.
How about this, Elizabeth? I'll go ahead and move you to room 3 where there's only 3 people.
Yes, please.
All right, let's go ahead and do that. All right, see you later, Elizabeth.
Go ahead. Bye-bye.
Okay, thanks. Okay,
I just realized I wasn't keeping time. Have you been keeping time?
No, but it's been like 30 minutes. I mean,
30.
Since since the breakout rooms began, do you mean? Oh, okay.
Probably like 2-3 minutes. So
okay. Yeah. So the ethical decision making. So I'm going to read this for everyone who is watching us on Facebook. So I'm going to read it, Kelly. Okay. Okay. So you are surprised to find you are interpreting for a patient you interpreted for a few months ago. You remember them because their last appointment was very memorable. They discovered their spouse was cheating on them because they contracted genital herpes. You don't believe the patient remembers you. And when the provider asks you if they have a history of sexually transmitted infections, the patient says no. You know this is not true. What do you do? So the options that we have are say nothing, it's up to the patient to decide to share this information or not. Option 2, switch to third person and explain to the provider that you have to clarify something with the patient, encourage the patient to be honest with the provider. And number 3, switch to third person and tell the provider that this patient has a history of genital herpes. So this is interesting because somebody in the, we had a discussion between two people, and I want to read that to you as well, okay?
That's fine.
Okay, so one person said, number 1, say nothing. It's not your place to take sides or use privileged information in an appointment, whether the client is being truthful or not. And then somebody said something super interesting, like this is tricky because you don't know why they're asking that question. So basically the person is saying like, we don't have any more context because we do not know if the question about STDs isn't done because the treatment medicine study the doctor is about to prescribe may have an adverse reaction on someone who has an STD. So this reminds me, you know, there is this anime character. You tell something about this anime character and they say like, but what if we die? And what if when we are dying, we go to hell? And then when we are in hell, they're going to torture us. I mean, that's a horrible example.
You went to a dark place there, Ncihc.
Yeah, I don't want to go to that dark place, but I mean, it's like this thinking, like one thing leads to another and another and another. So it's like kind of a little bit of overthinking. So so there is that on one side, and before, because I want to let you speak because I know you have a lot to say, but then this interpreter also describes that she had an appointment in which the patient told the interpreter that he was on drugs, that he was using some drugs. But then she I don't know how she got this information, but the patient just told that to her for some reason. And then when the doctor asks, do you use any drugs or something? And the patient said no. Then the doctor walks out of the room and because it was a pacemaker treatment, so somebody who is on drugs and is going to get a pacemaker can be like very it could be deadly for them or for some reason. And so the interpreter did was encouraging the patient to disclose this information. So this is a similar case, but one is drugs and a pacemaker, and the other one is an STD. Yeah. So I don't know. So what are your thoughts? It was super interesting when I read this.
Yeah, that's actually a really good point, is that we don't know why the provider is asking. I will say that in my experience, asking whether a patient has a history of STIs, that's typically a question that comes up during a yearly physical. That's the most common time I hear a question like that, or if it's a women's health appointment, let's say. I'm not sure if perhaps there's a treatment that could be impacted by that, but generally, so it could be another thing too, if we really want to overthink it, right? If we really want to get deep down in the nitty gritty, the patient was on treatment for it. So maybe the patient's on antibiotics and it's cleared up. And so maybe when we asked them if they had a history of STIs, they didn't understand the question. That's another possibility as well. That happens sometimes. Generally, when we're making ethical decisions, we don't weigh any one ethical principle over the other, unless it's like patient health and well-being, right? But if they're in imminent danger, or if it's something that could be life-threatening. So in that particular instance, I would honestly, unless the doctor made it explicitly known that like, hey, like I need to know whether you have a history of STIs, because if you take this medication or if you do this treatment, you could die. Then that would definitely be a situation where I would encourage, you always want to first encourage the patient to share. But then if they don't, you have to explain to them why you have to share that information, and then share the information, because that's part of the ethical principle of respect, right? We don't just go blurting out information. Now, there's certainly situations where, and this is my favorite example, the doctor has a syringe of a medication we know the patient's deathly allergic to. And the doctor is literally about to put that needle in the patient's arm. Do you have time to turn to the patient and say, excuse me, sir, this is the interpreter speaking. Would you be able to tell the doctor that you're allergic to the medicine they're about to inject in you? By that time, the doctor's probably already injected them. So it's an extreme example, but those are the examples where you don't really have time to weigh the ethical principles, go through the ethical decision-making process. You just kind of have to act. But I feel like those situations are pretty rare. But yeah, that case with the drug use and the pacemaker, especially when it's unclear and it's something as serious as a pacemaker, you want to do exactly what that interpreter did. Encourage the patient to share the information. And then if the patient says, no, I'm not sharing that information, then you say the interpreter unfortunately has to share this information if it could put your life at risk, which in this case, I'm not sure. So I just want to make sure, and that's why I have to divulge this information. That way you have full transparency because you want to make sure that people trust you. And at the end of the day, that trust might be damaged by you telling someone something, but you know, it's their life and you can rebuild trust. You can't resurrect someone from the dead, right?
Yeah.
So we are actually coming to the end of the breakout room. So I'm going to give them the 60-second notice that the breakout rooms are closing.
Okay. So I just wanted, I took while you were speaking, Kelly, I took notes of some of the things you said. So I took notes of limited knowledge. We are not doctors. We don't know what could potentially be life-threatening. It's the doctor's duty to actually, communicate when something is dangerous, when something is not. If you happen to know, it's just by chance, because we are not the doctors in the room, right? Background knowledge, culture reminds me of, we don't only know about the patient's culture, but medical culture. And I think that's important as well to these kind of interventions. The way that the question is formulated by the doctor, and also the risk of death, like if they're going to die or something really bad is going to happen.
Everyone's probably like, oh my gosh, Ncihc, what are you talking about? Talking about someone dying, coming back from the breakout room?
No, this is just, it was a discussion that we had with the Facebook group, but okay, the floor is yours, Kelly.
Oh yeah, no, you're fine. Yeah, we were just going over an ethical exercise that we were discussing in our Facebook group. So I wanted to ask everyone, how did that go? Did we have a productive discussion, or were we just kind of getting to know each other? How was it?
I was a bit late, so I was just getting to understand what was going on.
Yeah. But it's okay. It's okay. Yeah, Ncihc just posted our Facebook group in the chat if anyone was interested in joining. So did anything kind of jump out at you as far as the differences, or was there anything surprising?
We found a couple in our group.
Okay.
I think it was the California one had something about not providing provider information, like personal information about the provider to the patient. And that was something that wasn't present in the other two. So that was pretty interesting. Yeah.
That was a big one for me.
Yes.
Definitely.
Yeah. And there was a couple other ones, but I'll let someone else talk.
I have a question on that.
Yeah.
What kind of information about the provider would you be sharing with the patient when the provider is present and the patient?
You don't know. I mean, the thing is, so if you don't have a rule for something, well, sometimes some surprise situations pop up, and then you make a rule for it because you're like, I never thought that was going to happen, but it did. So I guess the only example I could think of is, let's say you've worked with a provider before, and let's say, you know, the provider has children, and you just start telling the patient, oh yeah, you know, you can trust this provider, they have kids, et cetera, et cetera. Or you might start sharing information about their family to try and, you know, this is just me kind of guessing. Of course, You wouldn't want to do that. That's not being impartial. That's not staying within your role as a medical interpreter. But, you know, hey, providers deserve to have a level of privacy too, just like we as medical interpreters. We need to make sure that our privacy is respected. Because if I go around and start sharing my phone number with everyone, then I'm going to have everyone calling me all day or night asking me to interpret for their medical appointments.
Mhm.
So I think it's important that they mention that, because it shows that confidentiality isn't just ethically, it isn't just about the patient. There are other parties involved here. So it's probably the best I can answer your question.
Okay.
Have to be imaginative for that one.
Yeah, I guess I have never encountered any situations like that.
Yeah, I can't say I have either. And I'm blessed to work with a lot of the same providers at a lot of the same facilities. And it would never occur to me to share something that I overheard about one of the providers with a patient. It doesn't seem right. It doesn't seem ethical, right?
Right.
So what else? What did we discover?
We noticed I believe it was the IMIA doesn't mention the elderly abuse, whereas the CHIA does.
Yeah. And I think, like I mentioned, I think the spirit of what the IMIA says would very much include something like elder abuse, whereas CHIA is more explicit about it, because IMIA, we have to remember, is the first code of ethics for medical interpreters. And obviously they've revised, and then CHIA came afterwards, and they kind of took it and they tweaked it a little bit. So I think all in all, obviously, if it's child abuse, if it's elder abuse, it's any kind of abuse that we become, that we find out about, we have not just a moral, not just an ethical, but a lot of times a legal obligation to inform the provider. But of course, we want to make sure, like we were discussing during the break, that we give the patient an opportunity to divulge that information if possible. Might not always be possible, but try.
Another thing, it's about Ncihc, where it talks protection of the notes that we take in the encounter.
Mm-hmm.
That is something very easy to forget, because we write notes all the time, and we carry sometimes with us that notebook that we forgot to get rid of the previous encounters notes.
Yeah, and I try and make it a habit when I'm leaving. Of course, like I said, I'm an in-person interpreter. So if I'm leaving a facility, it's almost like the receptionists know I'm going to come up to them and say, hey, can you put this in your shred bin for me? I like to just get rid of my notes before I even leave the facility, because you never know. Listen, crazier things have happened. You could, who knows, in your car on the way home, God forbid, get into a car accident, and then you have your notes in your car.
Yeah, that's what I mean. It's so easy to.
It's so easy. So you just being mindful is always super helpful. And I like that they have that example of the written notes. I mean, even if you're using symbols, like Ncihc's the queen of note-taking symbols. Ncihc has like her note-taking course on Interpremed, and she has her whole thing. Like she can take notes in just symbols, entirely in symbols, no abbreviation, hardly any abbreviations whatsoever, mostly symbols. And even those notes, even though you think, they're symbols, no one can understand them, better to be safe than sorry, and get them destroyed, get them shredded. So
yeah, when I interpreted here for the immigration, I had an immigration interview in New Zealand, and at the end of the day, they asked me for my notes, and my notes were going to be part of the evidence for the immigration.
wow. Wow.
Were they able to read them? Because
well, no, but I was not.
No,
but it doesn't matter. It was I was not allowed to leave the room with my notes.
Oh yeah.
Yeah. Wow.
I have a comment to make. Now that a lot of us that are working from home, we have to be very careful too on our note taking, because we're at home. It's so easy to to keep everything in a notebook and continue in the notebook until that notebook is completely full and then get rid of it.
Definitely.
It's just very important to be very, very careful because, you know, I think we have to remind ourselves of how important it is to get rid of them.
Yeah, I actually keep a different notebook for each purpose in my office. Fortunately, I don't do a lot of remote interpreting anymore, but I have a specific notebook that I bring with me when I go to interpret in person. And I always know automatically, I pass with the receptionist before I leave the facility. And the receptionist, like I said, if it's a facility I go to a lot, the receptionist might be like, hey, don't you need to shred something? And then if I arrive home and still have something in my notebook, first thing I do when I get home now is disinfect everything. And then before I set my notebook down, I open up my notebook to make sure there's nothing in there. And if there is, I tear out the page and I immediately put it in my paper shredder. So just extra levels of security is always helpful because, hey, we're human beings. None of us are perfect, right? Okay, well, now we're going to move on. I'm going to actually kind of give you, I guess, like my comparing and contrasting, showing you what I pulled from it. Might be the same as yours, might be a little bit different. It's okay. So these are what I saw when I looked through the codes of ethics. So I like to switch it up. I like to do the who, what, where, when, and why. You know, who can know confidential information? So the Ncihc says we need to keep the confidential information within the treating team. The IMIA says that we need to follow clinical parameters. So clinical parameters can be the hospital or the clinic's procedures and policies, which are hopefully informed by the law. Or it can just be, you know, perhaps they decided, okay, well, we have staff interpreters and those staff interpreters need to follow this specific code of ethics, right? So whatever we don't have here in who can know, we have down here in what information remains confidential. So this was kind of eye-opening to me. So the Ncihc says that we need to keep all information learned in the performance of our professional duties confidential. All of it. That's what it says. IMIA says all assignment related information must be kept confidential. And CHIA, the California Healthcare Interpreters Association, says all information learned during interpreting needs to be kept confidential. Okay. Okay. So that's what the Code of Ethics says, right? So who and what. Now, information we get from where. So I liked doing this actually. This really made me dig in and find something for the where. Information that we get from healthcare settings needs to be kept confidential. So information from within the healthcare encounter, says the Ncihc, IMIA, and CHIA. However, IMIA and CHIA also say that any information we get in a community context needs to be kept confidential. As in, we can't bring information that we've learned out in the community with these folks we interpret for and bring it into the healthcare setting. Well, that's interesting. So, and we'll get a little bit more into this in a minute, why we do this, why we have that bar. And when can we share confidential information? So the Ncihc says with patient's consent. The Ncihc, IMIA, and CHIA say as required by law. We would assume that as required by law and with patient consent have some overlap. Then IMIA and CHIA mention the homicidal suicidal intent. IMIA mentions child abuse. CHIA mentions child and senior abuse, and both mention domestic violence. And then IMIA and CHIA talk about institutional policies. I'm going to go ahead and mute some folks. All right. Sorry, I think we have some background noise going on. Boop, boop, boop.
Hey.
All righty.
Oh, Kelly, you're muted. Sorry, Kelly. I muted you.
Well, I am unmuted now.
Okay, sorry.
Oh my goodness, Nanji, China.
No, I use the mute all button, so that's why.
You're
Sorry.
fine. Alrighty. So the last one is institutional policies, standards of practice, and codes of ethics. It says code of ethics, but we know we have multiple codes of ethics. And lastly, this is why confidentiality is important. And this is the cool thing about codes of ethics, is that they're going to tell us why. Confidentiality is important because of the private and personal nature of the healthcare interaction. We talk a lot about private and personal things. And then maintaining trust among all parties, according to the Ncihc. Maintaining trust. Trust is pretty important in the medical encounter as medical interpreters. If we don't have trust, what do we have? Are people going to be able to work with us? Will people feel comfortable working with us? And IMIA talks about these vague consequences if not maintained. So there are consequences. Now, consequences can be legal consequences. Consequences can be consequences like, okay, well, the patient doesn't trust us, so they don't want to say a word around us. So that's why we want to make sure that we're really careful about what we share, right? And they say a couple of other things. So as far as understanding and explaining confidentiality, so the IMIA says the interpreter should be able to explain confidentiality. And Ncihc says we should be able to explain to the patient what it means in the healthcare setting. I think being able to understand and explain the concept of confidentiality is kind of important, because if it's a concept that we're trying to enforce, if it's a concept that we're trying to uphold, we need to be able to explain it and understand it. And then in terms of advising about confidentiality, so I mentioned this before, Ncihc says that at some point, or if necessary, we should advise all parties to refrain from saying anything they do not wish to be interpreted. That's a way to kind of preemptively protect confidentiality. And then lastly, we have that little tidbit of information about the provider's confidentiality, declining to convey to the patient any personal information about the provider from Ncihc. So we aren't just going to be talking about ethics. I said we're going to be talking about laws, and the law, or laws, mainly law, we're going to be talking about is going to have to deal with one that's a big one here in the United States. So can anyone tell me, I don't care if you're from the United States or not, what's the big federal law that protects patients' privacy in healthcare settings? Put it in the chat. Go ahead and unmute yourself and tell me. What is it? What's that big law? Hipaa. Someone said it in the chat. Yes, Hipaa. We have Yamna and Jordana and Zainab said Hipaa. Yes, Hipaa. So Hipaa's the big guy. Yes, Elizabeth, Hipaa. Hipaa is it. It's actually Hipaa with 2 A's. I always mess this up. It's just like, even though I'm a native English speaker, the word Wednesday, I have to say it in my head first. I have to go Wednesday, and that's how I write it. So I do the same thing with Hipaa. So Hipaa is the Health Insurance Portability and Accountability Act. So I always say it out loud in my head. Well, not out loud. I say it in my head. Health Insurance Portability and Accountability Act. That's why there's 2 A's. I also sometimes say it's not HIPPA because you don't want the PP in there. That's what I say. You have to remember things in funny ways sometimes. So Hipaa, the Health Insurance Portability and Accountability Act. So it was enacted in 1996. This is surprising to some people. I was alive in 1996. I'm not used to laws being enacted when I'm alive. I remember 1996 fondly. So the big thing for us that we need to remember is Title II and Rule 1 of Title II, which is the privacy rule. So who needs to follow the privacy rule? That first bullet point is really easy, because I'm probably mentioning it because we need to follow it. We need to follow the privacy rule. We are covered entities under Hipaa because we work in healthcare settings. So we need to make sure that we follow the privacy rule. So we're going to next talk about what is PHI and how we can de-identify PHI and when PHI can be used and disclosed. So this next slide is going to be a little bit overwhelming, but I promise it's a lot simpler than it looks. Preemptively, please don't freak out. What is PHI? Can anyone tell me what PHI stands for? Does anyone know?
Personal health information,
Close.
private health information.
Yamna got it in the chat. Protected health information. It's protected. We're supposed to keep it confidential. So, PHI. PHI is anything that is about the past, present, or future medical condition of a person, the provision of health care to a person, or the past, present, or future payment of health care of a person. So we can have a past, present, future medical condition. This patient, or let's say this patient has diabetes, provision of healthcare. This patient was seen at City Hospital. Past, present, future payment of healthcare. Mrs. Smith paid for her mammogram at City Hospital. Okay, so all of those would be considered in this list over here. But it becomes PHI once we add any of the 18 PHI identifiers. Again, overwhelming, it looks super overwhelming, but basically, if we have anything from column A, the left column, and it's combined with column B, then it's PHI. So, diabetes, Mrs. Smith. Mrs. Smith has diabetes, boom, that's PHI. If it occurs in a medical setting, if we find out about this information in a medical setting. Provision of healthcare. This is something that people did not understand when I worked as a receptionist at a clinic. You can't walk up into a clinic and ask, is Mr. Rosales here? I apologize, but I cannot give out any information as to whether or not someone's a patient here. What are you talking about? I'm his son. I dropped him off here. No, if I provide information about healthcare was provided to Mr. Rosales, that in and of itself is protected health information. Past, present, future payment of healthcare. If we find a receipt on the ground in registration at the hospital, and that receipt has a patient's first and last name on it and the amount that they paid. Okay, we know now that that person was provided healthcare at that facility. We now know that the person also paid for a healthcare procedure at that facility. And it doesn't just have to be names. It can be dates excluding the year. It can be date of birth. It can be the date of an appointment, phone numbers, any of these things on this list that could identify someone. So if you just have information that patient has diabetes, obviously that's not PHI, but the second you attach any of this information to it, even someone's email, this person at this email address has diabetes, boom, protected health information. It seems simple, but you'd be surprised how many folks don't understand what is included under the umbrella of PHI. So I also mentioned in the previous slide about de-identifying PHI. So de-identifying PHI basically means taking all of these identifiers, these 18 PHI identifiers, taking those guys off of that information. So we could have progress notes for a patient, but as long as everything is blacked out in a way to where you can't read it and you can't angle the paper in such a way to see the raised text to be able to try and decipher it, it's not considered PHI anymore if all that information is removed. So you can de-identify information by means of blacking stuff out, by shredding it. Good luck putting together a shredded piece of paper in my cross shredder. Please don't. That being said, PHI is any information or combination of information that could lead to the identification of a patient. So again, I will say this again because it's really important. If you're living somewhere and doing on-site interpretation, even information that doesn't necessarily seem like PHI, doesn't have any of those 18 identifiers in it, can be PHI. Even if you leave out a patient's name, age, gender, and simply say, I interpreted for a patient with insert rare condition or syndrome here today. Okay, they know you're a Spanish interpreter. They know you interpret in Richmond, Virginia, and they know that you're talking about someone from this linguistic community who has a very rare health condition. That information in the wrong hands could certainly lead to the identification of that patient. So it's just best to be careful. any sort of distinguishing characteristic can be dangerous. Like the woman with the dragon tattoo, that's one of the things on the 18 PHI identifiers, any identifiable image. So it could be something that's a unique identifier for an individual as well. So even if it's just a picture of a unique tattoo, that's considered identifying information. So in terms of when PHI can be shared, Hipaa says, the privacy rule says that we must follow what's called the minimum necessary requirement. So you should only share the minimum amount of information necessary to carry out your duties, and only with other authorized parties. So just because you're interpreting for a patient at a hospital doesn't mean that, okay, well, this information that I learned with the nephrologist, now we're going to go see the oncologist. Doesn't mean that you can go ahead and share all the information you learned from the first appointment with the oncologist at the second appointment. You only need to share the minimum amount of information necessary. And our code of ethics says that we need to allow the patient a chance to divulge that information first. Which brings us to our next group activity. So this is going to be, we don't actually have to use the slides this time. I can post the link again to the slides in the chat. But what we're going to do is we're actually going to just discuss briefly. I think maybe we can do this one for 5 minutes. How Hipaa and our codes of ethics differ in terms of confidentiality. So we're going to go into breakout rooms. Let's see, we have 16 participants now. So we're going to recreate the breakout rooms. Let's do 4 breakout rooms. And we're going to discuss how Hipaa and our codes of ethics differ in terms of confidentiality. So before we do that, I want to make sure, okay, Becky, you can listen, that's totally fine. I want to make sure that no one had any questions before we move forward, because I know we very briefly went over Hipaa. Any questions? Speak now or forever hold your peace. Okay, so we're going to go ahead and open those breakout rooms. Y'all should have gotten a request, and discuss how Hipaa and our codes of ethics differ in terms of confidentiality. We got folks heading to the breakout rooms. I may briefly text my assistants to bring me a glass of water, because I was remiss in getting a glass of water before starting with this presentation. So Ncihc, how's it going?
Oh, it's good. Some people are asking us if they're going to get CEUs from this meeting. So
we have not applied for CEUs for this. If we have enough interest, we can always apply retroactively, I believe. I can look into that. Would that be something you might be interested in, Ncihc?
Yeah, definitely. That would be very good, because we are recording all of this. So for example, I save the chat, and everyone who is participating. So we can always let everyone know when this meeting is going to count for CEUs. Definitely. And we will upload this to YouTube as well. So
oh goodness gracious, Ncihc. So Ncihc just told me today that we're going to do this on Facebook Live, and now Ncihc's just telling me that we're going to upload it to YouTube. It's okay. I'm no stranger to YouTube.
Yeah,
just hit those 1,000 followers on my YouTube channel. Ooh.
Yeah. So yeah, it's going to be available, and we will get those CEUs. Kelly and I, we are working, because we create new materials every month on interpretmed.com. So we are like juggling in between like so many things at the same time. And
we teach with Americans Against Language Barrier.
And we work because
we interpret.
Yeah.
What don't we do? And what am I after 5 o'clock p.m., Ncihc?
A housewife.
I'm a housewife.
Yeah. So so we are doing a lot of things, but definitely we are doing CEUs sometime in the future, hopefully by the end of this year. I think this will be a great want to get the CEUs with this meeting.
Yeah, and I am, we'll talk about that later. We'll talk about it later. We'll talk more about how this has kind of evolved into stuff. Leave it as vague as possible.
Yeah. Remember, everyone, just for everyone who is on Facebook, we have a big announcement at the end. So stay all the way until the end. You will be compensated for your time.
Yes. So we're about halfway through the presentation and it's been an hour. So this is probably going to be 2 hours.
Okay.
Yeah, it's just, this was one of those things where I just started it and wait, my husband's bringing me my glass of water. Hello, husband.
Goodbye,
husband. That's going to be on YouTube. It's going to be great.
Yeah. The assistant. And I was like, who is the assistant? And I was like, who?
I should have made my stepson come in here, but he would have probably made a weird noise or something. He's 10.
Okay.
But yeah, no, what I was saying was this whole thing has evolved. I initially thought like, okay, the codes of ethics just have like one sentence about confidentiality. Confidentiality is simple, right? It's a little bit more complex than I think we give it credit for.
Yeah.
So yeah, we're really getting into the nitty gritty of it. So aside from CEUs, do we have any other questions from folks? Do you have any questions for me, Ncihc?
No, it's super interesting. I'm super excited. I'm getting, my brains that are working very hard with this. And I have, what about journaling about the ethics, because now we are going to delve very deep into ethics, and I really like journaling. So I wonder, what if I journal about ethics? Will that help me?
Are you talking about like journaling about like interpreting scenarios, like things that have happened while you've been interpreting, or just like journaling about like your thoughts, like analyzing and processing the ethical principles?
Exactly. Analyzing, like, for example, here the talk we had about the ethical scenario about disclosing information, penicillin, pacemaker, drugs, and all that. And I added this here so I can like go back to it and maybe keep thinking about it, because sometimes you really have to think for a very long time in order to really like integrate that knowledge, or just see how everything, how the pieces are put together. I don't know. I'm a journal kind of person, so that's why.
I wanted to journal, but I haven't had the time. But I will say, okay, so first off, if you were to journal about your interpreting experiences with patients, that would be a big confidentiality thing, which I just want to put that out there. I want to make it clear that that is not what we were talking about. And secondly, I will say that kind of ethics is like working out. If you get really, really good at working through ethical scenarios, you'll find that when you're faced with ethical scenarios in the field, you kind of automatically jump to a similar situation. You're like, I've already worked through this situation. I already kind of know where I need to go from here. So when you do the legwork beforehand, it really makes you be able to think on your feet, think quickly, especially in those situations where they're critical situations and you need to make the right decision fast. Haven't had a lot of those, but when they come up, you want to make sure you're on your game. So we have about a minute left in the breakout rooms.
I wanted to say something, Kelly.
Sure.
This whole conversation, I'm studying philosophy at college, and I'm studying Plato. I don't know how Plato.
It sounds like Play-Doh, like,
Play-Doh. Okay.
Play-Doh.
Play-Doh. So I'm studying Plato, and the conversation that we're having about ethics remind me a lot about it's actually Socrates through Plato's writing, where two people are having a conversation like, what is courage? And why is a person courageous?
Oh, you asked me that one this morning.
Yeah, so that's why I'm so philosophical lately.
Oh.
And I kind of put like, I like to make connections between things, and this conversation remind me of the conversations people will have like very, back in the day about these concepts. But also I wanted to say that.
Sorry, real quick. I just want to let you know, I did close the breakout room, so people should be filtering back here in just a second.
Okay, so just very shortly,
Yeah, totally.
that I like to think about the codes of ethics because I think the interpreting profession is kind of like we are still trying to, even though we have organizations and codes of ethics, there is still a lot of material to cover in terms of the things of like how will the profession evolve.
Yeah.
So especially with remote interpreting and
Mhm.
all the, we have codes of ethics from New Zealand, Australia, the US, and now with remote interpreting are working for like people around the world. So I don't know. I think it's worth thinking about like as a whole. Why is ethics
Holistically.
important? Yes,
And
holistically.
that's exactly why I really wanted to compare the 3 codes of ethics that CCHI and NBCMI say that we need to know about. Because I feel like we read them once and then that's it. Once we're certified, that's it. But I really wanted to like get in the nitty gritty and just be like, how are these similar? How are these different? What can I learn from this? Because I've been a practicing interpreter for about 5 years now. And I always say, and Ncihc and I share this sentiment, that part of being an interpreter is being a lifelong learner. And so this is just kind of like full steam ahead. Like this is what we're doing with this. We're going to really look at ethics, and we're really going to look at, today we're looking at confidentiality. So that being said, we just broke up into groups and we discussed how Hipaa and our codes of ethics differ in terms of confidentiality. So what were we discussing? What are the conclusions that maybe we came to from this?
We were talking about the notes, the note taking, how it says we can share the minimum, something like that, like we can share the minimum necessary, and then also you're supposed to shred everything. So it's kind of like,
yeah, so the law, you know what, I'm going to let folks comment more because I don't want to detract from what anyone else has to say because I am a talker. Okay, I'm just going to say okay because otherwise I'm going to comment on it and add some stuff to it, and I want to make sure that I give everyone else a chance to talk. All right.
May I say something? May
Sorry.
I? This is Judith. Can you hear me?
Yeah, I can hear you.
Okay, so we were thinking that for us interpreters, we do discuss things that happen within tough sessions because we have to let it out, right? For self-care, but we don't say names, date of birth, or not identifiers of the individual patient. So I don't know how to word it, the difference between what Hipaa actually states in writing and our code of ethics, all 3 of them, but that's the one thing that we as interpreters do. We do discuss, you know, the tough sessions, death, bad news. So because we have to let it out, and hopefully we all discussing it with other interpreters only and not family members.
Yeah. So, and you know, this is actually something that I don't touch on in this presentation. So I am actually going to comment on it because I do think it's really important. So actually I have a Facebook group called Interpreter and Translator Peer Support Group, where we do kind of very generally discuss things, but also reach out to each other if we have something that we want to discuss, because we do, as medical interpreters, encounter a lot of really difficult things, and self-care is incredibly important. So I think the way that the codes of ethics are phrased kind of makes interpreters feel like, well, we can't share anything. Yet Hipaa says we only need to share the minimum necessary amount of information. So, okay, let's define necessary with authorized parties. Okay, well, that applies to protected health information. So that's what we need to protect based on what Hipaa says. So if we're omitting all of those identifiers like names, dates of birth, you know, any identifying characteristics, then according to Hipaa, we are respecting confidentiality. So that's where it gets a little bit tricky. Usually the way that I kind of reconcile it is I keep my mouth shut as much as I can. But if I have to talk about something, I actually try not to speak with local interpreters about it, because I do in-person interpreting. And if I'm talking with other interpreters who are in my area, who knows what identifying characteristics they might be able to pick out from what I'm saying, even if I'm trying to leave out as much as possible, which is why it's so great to have someone like Ncihc to talk to. Because oh my goodness, I was so nervous. Ncihc's all the Ncihc's all the way in the Dominican Republic. So it's really, I'm in Richmond, Virginia. So it's really nice to have these people who have absolutely no connection, no geographic connection with where you are. The nice thing with being a remote interpreter, one of the advantages is you're so anonymous, and it's nearly impossible to really hone in on the identity of a patient. So it's tough. It's really tough. You kind of have to reconcile your own personal and professional ethics with the professional codes of ethics. And I'm by no means saying that everyone should go around telling everything about their patients to everyone, definitely not. But I think it's not harmful, especially in the interest of self-care, to discuss those difficult situations. Ncihc says, I can only distinguish 3 types of voices: for the patient and for the provider. Yep. To kind of discuss those difficult situations in which we interpret, because we do have to take care of ourselves in order to really be able to serve and take care of other people. And Yamna, you have your hand raised.
Yes, thank you. So you were mentioning for purposes of self-care and also for training and coaching purposes, sometimes we need a little bit of guidance, and even doctors have case studies so that, you know, medical students are able to learn from their experience. So I think, you know, de-identifying the information, maybe even changing the gender, changing the age of the patient, just so that it's more anonymous and we can focus on the interpreting side of things would be helpful. And please do share information about the group you were talking about, the support group. I'd love to be a part of that.
Goodness, if you'll give me just 1 second. Oh no.
I'm able to share it for you, Kelly.
Yeah, if you could, that would be great. Ncihc's my assistant tonight. How the tables have turned. Ncihc, you know I love you. Yeah, that I think is really key here, because Ncihc and I are both, you know, interpreter educators as well. And what we do is a lot of times I have to come up with ethical scenarios, and I have a great ethical scenario in mind for a lot of these things. So what I usually do is I remove all the identifying information. I might limit it to one aspect of the scenario, and then it might bring in an aspect of another scenario to make it even more anonymous. And then I'll change all the identifying information to change the gender, change the age, change the name, even change the culture if it's applicable. And Ncihc just posted the link to the peer support group in the chat. You're welcome, Yamna. All right, so in the interest of time, we're gonna go ahead and proceed forward. And obviously y'all did your job. Now I'm gonna do mine. Our codes of ethics versus Hipaa. And I did the who, what, where, when, and why again. I feel like that's such a useful format. So who can we share confidential information with? We've already established that in the codes of ethics, we can share confidential information with the treating team, as long as we're following institutional policies. So sometimes the institutional policies are informed by the law. I mean, we hope so. And sometimes, you know, we might have medical students and things like that. And in that case, institutional policy says, you know, obviously, if they're part of the treating team, they need to know some of this information. And then Hipaa says that we can only share PHI with authorized parties. So authorized parties are typically the treating team, and institutional policies will follow what Hipaa says authorized parties are. So an authorized party might be, okay, if we have a minor child as the patient, the parent or guardian is an authorized party. Whereas if the patient is not a minor, let's say a 20-year-old, the parent in that case, unless there's a signed Hipaa authorization on file, will not be an authorized party. My husband is not considered an authorized party unless I designate him as such in my, what is it? Oh my goodness, I'm thinking of the thing in Spanish. basically right to release information. He has to be one of my Hipaa contacts in my medical file in order for them to be able to give my husband specific information. So what information remains confidential? Well, we just discussed, according to the Code of Ethics, it's supposed to be all assignment related information learned in the performance of our professional duties, including interpreting. Whereas HIPAA says only PHI needs to be kept confidential. So the bar is a little bit lower with HIPAA. So any health information that can be tied back to an individual, and authorized parties should only know the minimum necessary information, the minimum necessary PHI. Information that we get from where? Well, our Code of Ethics says not just in healthcare settings, but also in a community context. Not just about the patient, also about the provider. HIPAA says PHI, health information obtained in a healthcare setting by us being a covered entity under HIPAA. So I can go out in public and, for instance, right now, a big thing is your vaccination status. It is not a HIPAA violation for a private business to ask you about your vaccination status unless that business is a healthcare facility. Doesn't involve HIPAA at all unless they're a healthcare facility. If it's Jimmy John's down the street, the sub place, and they ask me before I enter, are you vaccinated? They can ask me that question. They're a private business and they do not fall under the umbrella of healthcare facility. So that information, even though it's health information about me, and you know it's about me, not PHI in that context. Context is very important with this. So when can we share confidential information? So in our Code of Ethics, we can share this information with patient's consent as required by law. Homicidal, suicidal intent, child senior abuse, domestic violence, as dictated by institutional policy standards of practice, Code of Ethics. HIPAA says we can share PHI with a patient's consent if the information is de-identified and if it is believed the patient presents a serious and imminent threat to self or others. So this one I actually had to look up what HIPAA specifically says about required disclosures in terms of harm. And it's very much in keeping with what the Code of Ethics says about the abuse, domestic violence. Basically, if someone is in danger and in apparent danger, then especially in some states, we're considered mandatory reporters. And why is confidentiality important? So our Code of Ethics say the private and personal nature of the healthcare interaction to maintain trust, and that if we don't honor confidentiality, there may be consequences, not just legal consequences, ethical consequences. And then HIPAA says, now HIPAA's a law, it's a federal statute. They're not going to talk about the philosophy of confidentiality. They're just going to tell you how it is. The enforcement rule, which is rule number 5 of Title II of HIPAA. There are consequences if HIPAA is violated. If HIPAA is violated, depending upon whether it's intentional, unintentional, criminal, civil, what have you. You could be looking at a couple $1,000s. You could be looking at tens of thousands of dollars. You could be looking at hundreds of thousands of dollars in fines and potential jail time. Big consequences, big consequences. So this is going to kind of be an open discussion for all of us to participate in. And we're not going to go into breakout rooms because I'm really curious what everyone thinks about this. Which do you think is stricter in terms of confidentiality? HIPAA or our codes of ethics? And in what ways? And why do you think this might be? Feel free to go ahead and speak up now or take a couple of seconds to think about it, because this is kind of a dense, this is like 1, 2, 3, 4 questions in one, really, if we think about it. What are we thinking? I'll do the Jeopardy music now. Any thoughts?
I feel like maybe HIPAA is more stricter because of it's a law, and there's fines to pay.
Okay. Any other
But they're
thoughts?
both just as strict.
Yeah.
They're very strict. And I think we have to protect the patient, and we have to protect ourselves as well, because we don't want to get into trouble, you know.
Yeah, because if we get in trouble, who are we going to help? Who are we going to help? Who are we going to interpret for if we're in jail?
We don't want to lose our jobs, and we don't want
Yeah.
to, you know, break that confidentiality of the patients having towards the interpreters.
Yeah. Because what our conduct as individual interpreters doesn't just reflect on us. It reflects on the entire
And all of
profession
them. Yeah.
of interpreting. And Yamna, you have your hand raised.
Yeah, I think that the code of ethics is stricter than Hipaa because Hipaa does have legal consequences. So it has to be a violation that constitutes, you know, enough of a crime. So that's why it's very specific with, you know, what constitutes a Hipaa violation. Whereas the code of ethics tries to kind of have us err on the side of caution. And like you all said, to kind of protect the profession and our reputation as individual interpreters, as well as, you know, the profession, and to have that trust that was mentioned in the different codes of ethics. So yeah, I think in terms of which is stricter is it's the code of ethics, and that's because it's not a regulated profession. You know, you wouldn't get your, I mean, I haven't heard of cases where someone's interpreter license was revoked because it's not as, you know, regulated as other professions.
Yeah, so in the United States, interpreters aren't licensed. They have their certifications. I certainly think there are cases in which interpreters have lost certificate. I don't think they're publicized. But I have to kind of agree with everyone, really. I think there are certain aspects in which Hipaa is stricter, and there are certain aspects in which our codes of ethics, excuse me. Everyone says code of ethics, but there's actually 3 that we should be looking at, are a little bit stricter. So to me, the codes of ethics are stricter in the sense that all information has to remain confidential, right? That's what they say. And we kind of have to use our best judgment as far as, okay, that's the standard. As far as deviating from that standard, that's kind of left up to our own sort of personal and professional ethics. Now, Hipaa, on the other hand, it only says PHI, protected health information. So if it's information about, oh my goodness, let me see if I can recall it right off the top of my head. So anything about past, present, future medical condition, anything about the provision of healthcare, anything about past, present, future payment for medical services for healthcare. Can you tell I teach Hipaa? Ooh. And then any of those 18 PHI identifiers. So I think what Yamna mentioned is that the burden of proof has to be a little bit higher for legal reasons. Like they have to have it clearly defined, right? Whereas, you know, our code of ethics, I think the reason why the bar is set at, okay, all information unless otherwise stated should be kept confidential. The reason why that is because it just like was mentioned a couple of times by a couple of different folks, that we have the whole reputation of a profession kind of hanging on the balance of a lot of times these one-on-one interactions between interpreters, providers, and patients. All it takes is one negative encounter for not just a patient, but also for a provider. I've worked with providers before who have unfortunately been burned in kind of a way by interpreters. By unfortunately, we do have some companies that are in practice that don't send qualified interpreters. And as a result of that, it gives this image, right? And that image is something that's very difficult to repair. So I think that's why, in that sense, the bar is a little bit higher. So this is more of an opinion question, but I kind of see everyone's point, and that's kind of where I'm at. I'm sorry, Naji, is that a hand up or is that a clap clap?
No, that's a clap.
Oh, that's a clap. Okay, just making sure. Just wanted to be sure. All right. Okay, so we're moving right along. So the big question, and I feel like we've already kind of answered this already, but can we break confidentiality? Can we do it?
No.
No? In no circumstances whatsoever. If we have confidential information, we have to hang on to it and we can't break confidentiality?
Well, it's only when it depends on if it's, child abuse, and if somebody is in trouble or problem, or
hit the nail on the head. There are certain instances in which we can break confidentiality. And then we have to think, okay, how are we defining confidentiality? And that's why I didn't give a definition of confidentiality in this presentation, because confidentiality, the definition is different if you're talking about Hipaa, because we're talking about a legal definition, versus if we're talking about the Code of Ethics. The Code of Ethics pretty clearly outlines what their idea of confidentiality is. So does Hipaa. Hipaa is only really concerned about confidentiality in terms of PHI. So our Code of Ethics, though, is a little bit more complicated as far as when we can break confidentiality. Obviously, if the law requires us to break confidentiality, we gotta break confidentiality, right? Other than that, it's kind of left up to our ethical decision-making process. So to end this conversation, to end this presentation out, I have some ethical scenarios we're going to briefly go through. We have about 30 minutes left, and I want to make sure that we have plenty of time for our announcement at the end, because we have an exciting announcement. So we're going to go ahead and we're going to start going through some ethical scenarios. So scenario one, while interpreting, a patient expresses to you that they don't want to go home after their appointment because they're afraid for their life. So we have to remember in this situation that we don't look at any one ethical principle when we are weighing our Code of Ethics. We have to look at all of the ethical principles. We're just touching on confidentiality here, but there are other ethical principles that we might be able to bring in. And really, our ethical principles, just because it's listed 1, 2, 3, 4, 5, 6, 7, 8, 9 in some cases, doesn't mean that 1 is more important than 9. We need to weigh them equally. There's one particular ethical principle that might kind of outweigh others depending upon the situation. So can anyone tell me? Now, I did this synthesis of the 3 main codes of ethics on InterpreMed. It's ethical decision-making made easy. So InterpreMed members have access to this video. But it's available in all the codes of ethics, and I kind of synthesized them, I kind of smush them together. So if you are familiar with any of these 3 codes of ethics, you can guess what some of these ethical principles are. So can anyone give me some guesses as to what our ethical principles are? I have
confidentiality.
Yeah, right. That's one of them. Yeah, we definitely want to talk about confidentiality. Yeah,
I wanted to thank you for touching on this part of it, because in none of the training that I'm taking, they talked about being a mandated reporter. And this is a very important subject, and I shouldn't be alone with the patient to begin with to hear this. So thank you so much. Go ahead.
Of course. And that's state specific, like not all states. And unfortunately, because I ran into this issue with the COVID vaccines in the beginning. Medical interpreter isn't a really well understood role, right? So of course, if general public doesn't understand what the role is, the law isn't really going to understand what the role is. So it's kind of ambiguous as to where we fall in the mandated reporter kind of abyss here. So I'm the type of person, I'd rather be safe than sorry. And I don't think there's a situation in which an interpreter has been prosecuted for not properly being a mandated reporter. However, always keep that in mind, and definitely be familiar with the laws of the state if you are an interpreter in the United States, and also if you are interpreting in the United States in general. So, okay, I see here we have transparency. Transparency is part of some of them. Neutrality is hitting on one of them. So I'll go ahead and reveal I have a little cheat sheet here to show me which ones are which. I have to know which box to click on. So, okay, neutrality. So that would be impartiality, not introducing your own opinions into the interpreting encounter. Advocacy, yes, advocacy is one of the ethical principles. So I actually kind of smush them all together because the Ncihc said advocacy is the ethical principle that determines when we can switch into the advocate role, which is when the patient's health, well-being, or dignity is at risk. So I like to kind of smush all these together. Like, yes, it's advocacy, but it's also, we kind of need to keep in mind the health, well-being, and dignity of the patient. Accuracy, yes, accuracy is another one. Let me make sure I'm clicking on the right box here. Accuracy and completeness. So it's accuracy. I believe Ncihc only defines it as accuracy. I like that Ncihc defines it as accuracy and completeness. Let me see here. Anyone else have any ideas what some of our ethical principles might be with all this synthesis of these ethical? Cultural awareness. Yes, someone got that one. I believe Ncihc calls it cultural responsiveness. Cultural awareness is what Ncihc calls it. Yes, professionalism is another one. Respect all parties, including autonomy. That's an important thing. Respect includes autonomy. Ooh, okay, it just says Oksana Melnick. Okay, Oksana, you're completely right. Professional development in the Ncihc is separate from professionalism. In Ncihc, professional development falls under professionalism. And so we have one here and one here. So this one, this little one that's a question mark that's still left in gray, limitation of practice, very close, very close. It's all about staying in your lane. I'm not going to get on y'all for getting the exact wording. Maintaining boundaries. So it's making sure that you're maintaining the boundaries of the interpreter role. You're either a conduit, a clarifier, a cultural broker, or an advocate. Chances are, if you're doing anything outside of that role, are you being an interpreter? Are you maintaining proper boundaries? And I like to include this last one. It's kind of a bonus. It's one that appears on one single code of ethics that doesn't appear in the other two. And that's in the IMIA Code of Ethics for Medical Interpreters. So one of their ethical principles is using unobtrusive means to maintain the flow of communication. I like this one separately because I think flow in and of itself and being unobtrusive, fading kind of into the background, I think that is an important thing. I always say, I know I'm doing a good job when I'm interpreting, when people forget that I'm there. It lets me know that we have good flow. We've reached a nice flow state. And that to me means that I'm almost invisible. It's the only time in my life where I like being invisible. I know things are going well, and I know that we have a decent level of rapport and flow of communication between the patient and provider. So when it comes to our little scenario that we discussed here, while interpreting, a patient expresses to you that they don't want to go home after their appointment because they're afraid for their life. Which ethical principles do we think come into play here? You can answer in the chat, or you can unmute. Hopefully no one talks, and not everyone talks at the same time, but we can try this. What other ethical principles, aside from confidentiality, we've already established that one, come into play here? Boundaries, get a social worker. Advocacy, well, because we have the health and well-being of the patient coming into play here, right? Anything else? Okay. Well, let's see what Kelly has to say. I'm going to go ahead and close my, sorry, I have so many things up on my window blocking out my PowerPoint. Okay. So this is what I had to say. And so I asked myself, what does Hipaa say? And what does our code of ethics say? Right? So Hipaa says that we should disclose because we're looking at patient harm. It's not suicidal or homicidal tendencies, but we are talking about abuse. And in this case, this is basically a disclosure that that is permitted either by federal or state law or both. However, our ethics are always more complicated, right? So our ethics say that the principle of respect comes into play here. So we had maintain boundaries, advocacy as our ethical principles. I say respect comes into play here because if we learn about this information, and you know what I do not like, is when people tell us, well, if you learn information outside of the presence of the provider, that means you're doing something wrong. Not always. You'd be surprised what patients sometimes feel obligated to disclose to me. Oh, look at you, Yamna. You're just going ahead and answering all my questions for me in the chat. While I'm sitting in the waiting room, I try to sit as far away from the patient as possible. I try to be in my phone, like they see I'm busy. Hopefully they won't bother me. Of course, being as respectful as possible and being kind and smiling. But sometimes people will be like, yeah, I just want you to know. And then I'll be like, I'm sorry. And they'll just keep on going. Or sometimes the provider will just walk out of the room and I'm scrambling behind the provider and the patient says something. Or I might have interpreted for the patient before. Or sometimes these things happen, or the patient grabs you as you're walking out of the clinic and you didn't realize they were there. Listen, interpreting isn't nice and clean and easy and fits into a nice, neat little box. A lot of times interpreting can get messy and we need to acknowledge the reality of that situation. So, okay, the patient has in some way, shape, or form disclosed to you that they don't want to go home after their appointment because they're afraid for their life. So we need to encourage the patient to share this with the provider if possible. And that's in keeping with the ethical principle of respect. So the reason why I say if possible is, and this is where you need to use your best kind of emotional judgment. This is where emotional intelligence really pays off in interpreting. What if you encourage the patient to share it with the provider and the patient says, oh no, I'm getting out of here now. Like this situation isn't going away that I like, and I'm just gonna leave. If you think that might happen, you might not be able to encourage the patient to share it with the provider, especially if the patient's like, please don't tell anyone, please, please, please. I will leave here if you tell anyone. A little bit different. I'm gonna check against Yama, see if we have the maintaining boundaries and accuracy. Everything said will be interpreted. So this situation is a little bit vague. And in this particular instance, we don't know if this was uttered in the presence of the provider or if the provider is in the room and the patient kind of whispered it to you. So yeah, if this is said in the presence of the provider and the patient says, yeah, I don't want to go home after my appointment because I'm afraid for my life, don't tell the doctor. That kind of puts you in an awkward position. And then you have to be like, well, I did tell you at the beginning of the session, they do have to interpret everything accurately and completely. Kind of letting people know that just that respect, that level and layer of respect always needs to be there. And then inform the patient you must share with the provider if possible. So if the patient doesn't share with the provider, you need to tell them, listen, I have to tell the provider if possible. Now, if the patient, you already got pushback from the patient when you encourage them to share with the provider, you might not be able to do this. But this is in keeping with respect. Again, this is also in keeping with confidentiality because you're explaining the limits of confidentiality, which we now know is part of our ethical responsibilities as medical interpreters. And last but not least, this is what Yamna was saying in the chat, advocacy, the patient's well-being. So at the end, you have to share it with the provider. You have to. You might not be able to morally live with yourself if something were to happen to that patient. You also might face legal consequences. It's not unheard of. And then, of course, the health and well-being of the patient. At the end of the day, we're in a healthcare capacity. We're in a healthcare setting. And so the patient's health and well-being is going to be top priority. That's the only ethical principle that kind of outweighs all of the rest when it counts. When the patient is facing imminent danger or serious harm. That's when that kind of shifts to the top of the list. So any questions about this scenario? Because we have a nice, fun little group activity coming up. All right. So we're only going to be in breakout rooms for about 10 minutes. And again, I'm going to go ahead and copy and paste the document here because it will have, you know what? It doesn't have the ethical scenarios in it. Ah, I just realized I forgot to add the ethical scenarios. So, all righty. Let me do this. Let me think. Got to think of my feet here. I will. You know what? Since we only have about 20 minutes left, instead of doing breakout rooms, and I feel like we have kind of dwindled, well, we have 15 participants. Okay. Well, fudge waffles. That was supposed to be in the document, and I realized I omitted it from the document. No, I didn't, did I? Oh my goodness. Ncihc, can you do me a favor and double check that document that I just pasted in the chat and make sure the ethical scenarios are in there?
Okay, let's see. Scenario 1. Let me see. Another group activity. Scenario A. You are interpreting for a woman who
Yes.
you have.
Beautiful.
Yeah, it's here. Mhm.
You've answered my question. So never mind then. We will go into breakout rooms. Sorry for that. I seem to be getting a little mixed up here. So we will actually go into breakout rooms. We're going to go ahead and recreate the breakout rooms. We have 15 folks here. So we will create 5. We'll do 4 breakout rooms. We're going to create 4 breakout rooms. And I see we have about 3 to 4 people per each room. So what we're going to do is, yeah, 4 worked out perfectly because we have 4 ethical scenarios. Room 1 will have scenario A. Room 2 will have scenario B. Room 3 will have scenario C. And room D will have, excuse me, room 4 will have scenario D. Can you tell it's been a long day for me? And what we're going to do is you're going to discuss this ethical scenario. What are the implications? What are the implications in terms of Hipaa? What are the implications in terms of the codes of ethics, especially in terms of confidentiality, but we might want to drag in some additional ethical principles. And what would you do? So I don't believe we'll have a chance to really go through these scenarios in depth, but at the very least, you'll be able to flex your ethical muscles a little bit. We'll maybe go over them a little bit briefly in the end here. So I'm going to go ahead and put you all in your breakout rooms. Are we all good? Do we know what we need to be doing? I hear no nays. Okay, I'm going to go ahead and open up the breakout rooms. And remember, room 1A, room 2B, room 3C, room 4D. How's it going, Ncihc? It looks like it's getting dark over there.
Yeah, it's 7 p.m. in here, so it's getting dark.
Samesies.
Yeah, you know what I want to do? I want to read the scenarios for the people on Facebook because we have like 4 people watching us on Facebook.
Okay. We are actually going to very briefly be going through them once everyone gets back. But if that's what you'd like to do now, just full disclosure, so you know what we're doing after we come back.
Okay, I'm just going to read them to give them some ideas. Maybe they can think about it later.
I'll drink some water.
Okay, scenario A. You are interpreting for a woman who you have interacted with in your community, but that you do not have personal ties with. The doctor asks her if she has children, but she says no. You know she has children. Okay, so that's scenario A, right? And all of these are about confidentiality, right? Okay. Scenario B. At the patient's previous appointment at facility A, you interpreted for them when they got their test results, indicating they had an STI. Oh, that's the same scenario we were talking about earlier. When the doctor at facility B asks if they have ever had an STD, the patient says no. However, when the doctor asks if they are taking any medications, they disclose that they are taking antibiotics for an infection. The doctor moves on. Okay. Scenario C. At the patient's previous appointment at facility A, you learn the patient is allergic to penicillin. When the doctor at facility B asks the patient if they are allergic to any antibiotics, the patient says no. And the last one, you are interpreting for a patient when the doctor informs her that she likely has cancer. Once the appointment is over, You go with the patient to reception to assist them with scheduling follow-ups with the English-speaking receptionist. The patient's mother, who was waiting in the waiting room, approaches and asks their daughter if everything is okay. The daughter starts crying and mom asks, "You was wrong."
Nanji, sorry, real quick, I might need some technical assistance.
Okay.
Yamna is not in room 2, but I don't know how to send. Oh, there she goes. She just got in room 2. Never mind.
She got her some
Crisis
intro. Okay. But some people have not joined. I can see Rasha, Lily, and Michelle are still here with us. Oh, they are still joining. But the others are here. So those were the scenarios for you, Facebook people. I hope you have a comment, something to say. Let's check.
Yeah, so
Okay.
I think it's not going to be a problem that we're repeating scenario B because the people were in breakout rooms when we discussed it
Yeah.
earlier.
Okay. Yeah, these are very interesting. Actually, we share scenario B on our Facebook group about the STD, and a very interesting conversation.
This is actually a slightly different scenario.
Really?
This is slightly different because the one you were talking about was, you remember the previous appointment because the patient's spouse was cheating on them, and that as a result they got an STI, whereas this one is the doctor at facility B asked the patient if they've ever had an STD. The patient says no. But when the doctor asks if they're taking any medication, they disclose that they're taking antibiotics for, quote, an infection. Slightly different.
Oh yeah, it's just like, but you know, and something that's interesting about these scenarios is that we have limited information, right? Because we in real life, we have to make the best decision with the information we have at hand. We cannot know it all. So
I will say though that in remote interpreting, a lot of times you just get on in the middle of the encounter and you have absolutely no idea what's going on. And sometimes you're literally, the extent of the information you have is what we have here in these scenarios sometimes.
yeah, exactly. Sometimes maybe I have probably faced many ethical scenarios, and I mean, I've never known because I don't know. I just jumped in the middle of the call. Oh, the previous interpreter disconnected. Can you keep interpreting? I was like, okay, yes, no problem. And I don't know what happened before because, you know, I cannot be everywhere. But, you know, this scenario B.
Actually, hold on just one second. Yamna, it seems like your partner keeps on dropping out of the breakout room.
Yeah.
Are you there, Yamna?
Yes, I'm sorry. I think my partner had her microphone muted. I wasn't getting any feedback from her. I'm sorry.
No. Well, we only have a couple of minutes left.
That's okay. Don't worry about it. I'll just
you
sit
can
this
hang
one
out
out.
here
It's
with
okay.
us.
Yeah.
It'll be a party, you know. Where's my feather boa, Nanji? Remember the red feather boa I had wearing that one time on one of our meetings?
Oh yes, yeah.
Yeah, I showed up looking like a hot mess. I had a feather boa and I had sunglasses. It was for April Fool's Day. I'm the
That
fun
sounds
one.
great.
Can I be the fun one, Nanji?
Hmm?
Can I be the fun one?
Yeah, go ahead. I'm the boring one.
Okay.
I'm sorry to interrupt. I'll just let you guys go on with it. I'll
Oh,
just
no, you're
kind of
fine.
mute myself.
You have been an absolute pleasure, Yamna. You've been contributing quite a bit. We appreciate it.
Oh, I really appreciate it. I love, a webinar or a workshop. This is more of a workshop that's got a lot of participation and, it gets you really working on the material rather than just, sitting there. So I really appreciate it.
You know what? Nanji's been on me about it. I actually met Nanji when I was giving a mental health interpreting presentation she asked me to come present for InterpreMed. And so that's something I've actively been working on, is making things more interactive. So I'm glad that you say that. That makes me feel very validated.
Yeah, it really helps.
I'm glad.
Yeah, Kelly has improved a lot, because she's teaching with ALB, she's teaching with InterpreMed. So I think the more you do something, the better you get at it. I can definitely see it. This meeting has been wonderful, really. Has been very good.
Yay.
Mhm.
Yeah, and I can't let you compliment me without me complimenting you. Because we work together a lot. You know, we have all these scripts that we work on, and we do a lot of translating. We do a lot of proofreading each other's work, just trying to come up with the best translations for things. And we have the same language pair, which is great. I'm a native English speaker, you're a native Spanish speaker, so we kind of complement each other in a lot of ways. But Ncihc's English, your English has gotten, I feel like even my Spanish has gotten better, like just from us working together. It's amazing how working together with peers can really, really bring your skills to the next level.
Yeah, definitely, definitely. And you know something, Kelly is so good with words. She uses like, for example, the other day we were in the ethics club, like, no, this script is super simple, it's super easy. But I was like, you know, there are some words, Kelly, that are not that simple, not always that easy, because she doesn't notice that she uses like a lot of words for a lot of things. And so it was, but that's good, because I have learned a lot from interpreting translating Kelly's material. And sometimes I write materials and then Kelly translate them from Spanish to English, and I love it. Every time she says like, oh, I'm going to translate, I'm like, yes, finally, yes, I'm going to see how to translate this complicated phrase. So it's always super exciting.
Yeah, that's great to have a native in both, languages working together. It's perfect.
Yeah, and I've actually been starting to kind of collaborate and participate more. I'm actually going to go ahead and close the breakout room. So in about 60 seconds, everyone's going to be back with us.
Okay.
But I've been participating more. InterpreMed, we have these peer practice groups where we actually get to practice with like scripts on InterpreMed and stuff. And I've even like been in some of the Arabic groups. I'm not an Arab, I don't speak Arabic at all. And just, it's really amazing how much you learn from working with people who have a different skill set or a different skill level than you. It's really enriching. And I feel like in a lot of ways, Ncihc has her strengths, I have my strengths, and we just kind of learn from each other and compliment each other a lot, and not just compliment, but also complement each other a lot. So yeah, it's good. Everything's good. All right. Well, it looks like everyone's going to be back in about 7, 6, 5, 4. I feel like we're about to launch a spaceship.
Yeah, but we are, because we have the big announcement.
Yes, I know. See, this always happens with my presentations. I always go over. So we might go like 5 minutes over.
Okay, it's okay. You know, it's good that we started with 15 people and we still have all of them. -1,
People
but that's
left and some people kind of joined, and some people, you know, I feel like I saw a lot of people drop off in the first like 5. They're like, oh, this is not what I was expecting. It's okay. It's okay.
Yeah, it's okay.
All right. How was it?
These are good ones. Even letter A is simple and basic, but there's so much to talk about it.
There's layers. There's definitely layers.
And the more we talked, the more we discovered, and the more people thought of,
Yeah. And I mean, that's what, and this is something that Ncihc and I were talking about, not this breakout room, but last breakout room, because we are live recording this. We want to make sure that we're kind of filling in the gaps with some content here, some enriching and engaging content. We were discussing about how really going in depth into these ethical scenarios and kind of flexing your ethical muscles is like working out. You become better at it by doing it. So then when you're faced with an ethical scenario in the field, you're already like, I've already worked on an ethical scenario like that. And you can kind of, it's not like a shortcut, but you're able to do it more efficiently to where you can really think on your feet better. So doing something like this is really good for you as an interpreter, just to kind of build on your ethical skills, right?
I want to add something, Kelly, as well. So if you're somebody who is like very insecure, when you read through this and you come up like, when this happens to me, I'm going to say this thing this way, like this. And it's like it mentally prepares you for the situation, because sometimes some people can be like, I'm super shy, and sometimes it's hard to get it all out. So when I'm able to do that before do the real thing, it helps a lot with my confidence. So
Yeah, and I will tell you, oh gosh, Ncihc, see, this is how we always go. You say something, and then I say something, and then you say something, and then it's such a, I will say I agree with that 100% because believe it or not, I've kind of like curated this kind of like ability and persona to kind of come off as an outgoing person, but I'm actually very much an introverted person. And I do struggle with self-confidence as well. And it's part of being a perfectionist, right? Ncihc knows what I'm talking about. But I even have like a prepackaged phrase that I use now because I practiced it so much from ethical scenarios for when I'm dealing with a provider that is saying rude things to a patient or a patient that's saying rude things to a provider. So you can really figure out these strategies and you can kind of come pre-prepared to these situations with these strategies. So I agree 100 bajillion%.
Kelly, to interrupt, what is the phrase, please? Share.
This is the interpreter speaking. I would like to remind all parties that I will interpret everything accurately and completely, no matter the content of the message.
Thank you.
Because it's a nice little, of course, I try and say it very kindly. I said it there very like in a very normal Kelly way. It's almost disarming. It's not confrontational. It's just letting people know like, hey, I'm going to interpret everything. Like, even if you're calling the patient a bad name, I'm going to interpret it. And it doesn't matter if it's a bad thing that you're saying to them, I'm still going to interpret it. And then of course you interpret that into the patient's target language. And then the patient knows, okay, these things that are coming out of the introduction is crucial. You know what? Even if you include that you're going to interpret everything accurately and completely in the pre-session, sometimes I feel like the pre-session goes in one ear and out the other. And so sometimes you do have to do those third person interventions again later on in the encounter to reiterate things from the pre-session. Doesn't happen always, but it does happen sometimes. So it's also a good way, that phrase, to let patients know, don't shoot the messenger. Do not shoot the messenger because what's coming out of the interpreter's mouth are not the interpreter's words. So what did we think of scenario A? We had Becky, Shell, Rasha, Zainab. Sorry if I'm pronouncing your name wrong. What do we think of scenario A? It is perfectly all right if we are not. Oh, yes, Becky.
And we talked about a few things. Where are you guys? We were talking about how I just started looking at it real basic and thought it's not, first of all, it depends who she's talking to, the way it would make me feel. If she's talking to, this is an example I used, a diabetes doctor or something, and the fact that she doesn't want to disclose that she has children, I might not dwell on too much. As compared to if she was seeing like an OBGYN, then I may have to start thinking more about how much I need to, I don't know, for lack of a better word, intervene or do more. I thought too that if it's not OBGYN, and even if it is, maybe that it's not necessarily putting the patient in danger or in harm. And so I could probably go home that evening and probably sleep okay on it and not worry that, oh my gosh, she's gonna overdose or she's gonna take meds or she's gonna die or someone's gonna do her harm. But then we started talking about the OBGYN situation and it went on. And then another person in the group said something about prescribing drugs that may alter her state of well-being and then causing her not to provide good care for the children that she has at home. And that's going even deeper.
Yeah, it's all very, I think you're touching on a really good point here, is that it's all very, context is really important, right?
Yeah, and I was trying to think, Judith, you're on here, you can hear me. What's the name of that training that they tell us that we kind of adjust what we do based on that split second of information? And I can never remember it. It's the greatest training and it's the greatest concept to live by and to accept, but it's kind of like it's kind of like your instantaneous decision making that you have to do based on an incident or on a moment or on a phrase or on what in that situation.
Like your gut feeling?
Yeah, or even taking into account all of these things that you're asking us to take into account, like Hipaa or the ethics, or because there's nothing in Hipaa that says anything about this, but there sure is in our ethics, right?
Yeah, ethics gets really tricky with this one. So what I said was, so this is kind of like my really, really brief thing. So Hipaa says it's not PHI because this is information that we learned out in the community. Whereas our code of ethics says this is concerned with confidentiality because even though we learned it out in community, it's coming into the healthcare encounter. So ethics says, again, depending on the context, based on this, how general it is, I'm going to say that the patient's health and well-being is likely not at risk if the patient is giving false information. I say false information with quotes because we need to make sure that we're keeping in mind impartiality. Sometimes we jump to conclusions in these situations, like, oh, they're trying to hide something. They're being tricky, you know. It's, remember, impartiality, we got to be impartial. Confidentiality, remember, information learned in community, doctor doesn't necessarily need to know. And also, I like to ask, did you interpret the question correctly? Did you have your listening ears on? And did you interpret everything the doctor said accurately and completely? So this is where we have to engage in some professional reflection, potentially. It seems like a simple question, but maybe it was a question sandwiched in between two other questions. Potentially they didn't understand the question. Maybe it was how we interpreted it. We don't know. And part of professionalism is holding yourself accountable. And also, you know, we want to make sure that we're being accurate and complete. So perhaps a little bit of a simplification of this scenario, but that was what I had to say about it. And I apologize. I would love to hear from everyone about the scenarios that they went over. But in the interest of time, I'm going to go through the scenarios, show my analyses of the scenarios real quick. That way we can get to our big announcement at the end. And then, yeah, I'm just reading the chat. So we're going to have our big announcement at the end. And then after that, a demand control schema. Yes, I need to learn more about that. Absolutely, Becky, that was what you were talking about before. And then after we make the big announcement, then we can come back, and if we want to discuss anything more in depth, we can certainly do that. So scenario B, at the patient's previous appointment at facility A, you interpreted for them when they got their test results indicating they had an STI. This is similar to a situation that we discussed during one of the breakout rooms, but not the same. When the doctor at facility B asks if they have ever had an STD, the patient says no. However, when the doctor asks if they're taking any medications, they disclose that they're taking antibiotics, quote, for an infection. The doctor moves on. So Hipaa says patient consent is sometimes required for PHI to be shared between healthcare facilities. Sometimes. It's really specific, excuse me, for Hipaa. And because we are not the doctor's offices communicating with one another, those requirements are not as clearly outlined for us. We don't really need to know those requirements. But our ethics can guide us. So chances are, now we could think of some really outrageous situations in which the patient's health and well-being would likely be in danger, potentially. But if the patient is giving quote unquote false information, again, maybe they didn't understand the question, their health and well-being is not necessarily at risk. In addition, confidentiality, you're not necessarily justified in sharing information between two different treating teams, because the second you leave one facility and go to another, it's a different treating team. Even if you're going to two different facilities or two different medical offices in the same building, in the same medical office building, technically two separate facilities, two separate treating teams. Not necessarily justified. And when it is justified, it's health and well-being of the patient. And in addition, there's kind of legal ramifications of abuse, of all of those things that we mentioned previously. And then respect. The patient here, potentially, it appears they may be making a choice because they said that they're taking antibiotics, quote, for an infection. They're being probably intentionally vague here. They might be ashamed or embarrassed and they don't want to share specifics. Part of respect is honoring the patient's own decisions. That's part of autonomy. So in this particular instance, given how it's phrased, the ambiguity of it, I probably would mind my own business. Again, ethics are not black and white, but that's how I'd handle it. Scenario C. At the patient's previous appointment at facility A, you learned the patient is allergic to penicillin. When the doctor at facility B asks the patient if they're allergic to any antibiotics, the patient says no. So Hipaa says, again, patient consent is sometimes required for PHI to be shared between healthcare facilities, but ethics say the patient's health and well-being will very much be at risk if the doctor is not aware of the allergy. They have an allergy to penicillin. We don't know how severe that reaction could be. It could be an anaphylactic reaction. That ambiguity is enough in there. That possibility is enough for that ethical principle of advocacy, of that health and well-being of the patient to kind of kick in. So out of respect, we need to encourage the patient to share the information about the allergy with the provider. Then if the patient decides not to tell the provider, we don't know why, we tell the provider about the allergy. And it's confidentiality, it's a necessary disclosure. Somewhere in here, for respect, you may want to explain to the patient that you have to tell the provider because their health and well-being is at risk. Breezing right along. Scenario D. You're interpreting for a patient when the doctor informs her that she likely has cancer. Yes, encourage. They may not realize penicillin is an antibiotic. That is very correct. That is very correct. So you're interpreting for a patient when the doctor informs her that she likely has cancer. Once the appointment is over, you go with the patient to reception to assist them with scheduling follow-ups with the English-speaking receptionist. So you're facilitating that interpretation there. But the patient's mother, who is in the waiting room, approaches both of you and asks their daughter if everything is okay. And then the daughter starts crying and mom asks you what's wrong. So chances are, so we don't have a lot of information here. Oh, see, I have it here. I have it here in this one that it's a 24-year-old patient. Given how it's phrased and given the fact that the daughter was alone in the room with the provider who gave her the cancer diagnosis, we're assuming that the patient is not a minor. I would say that the patient's likely not a minor. So in that instance, that information likely is confidential information, because if the patient were a minor, then disclosure to the parent is pretty much necessary. In that case, the parent would likely be in the room. But we're just going to assume she's 24 years old. That's what was supposed to originally be in the scenario. This is a little tricky. So Hipaa says PHI can only be shared with authorized parties. And so we have to ask, is mom an authorized party? The only way mom would be an authorized party is if we have patient consent. Now, we can have verbal patient consent. We can have consent on file with the doctor's office, that Hipaa form, that release of information, Hipaa contact form. We don't have that information. We don't know that. So you got to be careful. And ethics, in addition, says we can only share within the treating team. Otherwise, we need the patient's consent. So in this case, the ethics and Hipaa are kind of on the same page. However, ethical principle of respect. It's the patient's choice when and how, or if, because maybe the daughter never wants to tell her mom she has cancer. That's her choice. If they're going to tell mom, we need to respond in a way that is respectful to mom while giving the daughter an opportunity to handle it. It may seem cruel, leaving the daughter to manage that situation on her own, but that's not her job as an interpreter. And lastly, impartiality. We need to refrain from personal involvement. Again, we cannot forget respect. So what I would do in this particular instance, it's a little strange, but if I saw a daughter crying and mom came up to both of us and asked me, well, what's wrong? Is everything okay? What happened to her? Why is she crying? Then I might say, oh, let me go get her some tissues. and walk away and go to reception and maybe fiddle around, maybe grab a box of tissues. I don't have to get the box of tissues. It would seem silly if I didn't get it if I said I would. But that gives me an opportunity to step away and let the daughter resolve it. Then that way, maybe when I come back, they have already had this resolved and I hand the daughter the tissues. But if mom keeps on pressing me, I have to be like, I'm sorry, what happens in the room stays in the room. I can't really share information like that. And then it really is up to the daughter to share the information because it might be kind of awkward otherwise. That's just what I would do. So I want to make sure we get to our special announcement. I know this has been a long presentation. I do apologize, but thank you so much for hanging in there with me. All 13 of you. Wow. Okay. So we compared, contrasted what the Ncihc, IMIA, and Ncihc Code of Ethics say about confidentiality. We've explained our legal obligations to confidentiality. We've analyzed how our legal and ethical responsibilities to confidentiality overlap, and we've identified if and when confidentiality can be broken. So that was Let's Talk Ethics, Confidentiality for Medical Interpreters. So Ncihc, do we want to record the announcement?
Yes. Mm-hmm.
Okay, we're going to record the announcement then. So this is kind of big. This is our first like live announcement with InterpreMed, a little bit later than I was anticipating, but hey, you know. All right. Y'all ready? So I said we had a big announcement. So this is our big announcement, y'all. You ready? So we now have, InterpreMed is going to have an ethics club. So just like Ncihc has her advanced note-taking club, the memory club, right? So the memory club will now include not just our advanced note-taking club. The memory club might be renamed. We might rename it. We've been discussing different names, some silly names too, with memes. But our memory club will include our advanced note-taking club, where we have access to all of our symbol practice exercises, note-taking practice exercises, transcriptions, note and symbol transcriptions of different interpreting scripts available on InterpreMed. We have the memory club or the advanced note-taking club meetings that are usually once or twice a month, Ncihc?
Twice a month.
Twice a month.
Every 2 Saturdays. Mm-hmm.
Okay. The ethics club, on the other hand, will meet a minimum of once per month. It will be about 2 hours like today. Hopefully I'll get better on the timing. And we will be going over, bit by bit, we'll be going over each different ethical principle. So we start off with confidentiality. So we're going to move on. We're going to talk about the health, well-being, and dignity of the patient, advocacy. We're going to talk about impartiality, maintaining boundaries, respect, professionalism, professional development, accuracy and completeness, cultural responsiveness, and hey, we might even get into using unobtrusive means to maintain the flow of communication. So we're going to have a bunch of different exercises. We're going to have quizzes. We're going to have, oh my goodness, we came up with so many different formats this month for the written exam study guide. So lots of stuff to practice with. And then any extra stuff that y'all want. I'm going to be posting a Hipaa training that I will be giving, like a pre-recorded Hipaa training. So lots of exciting stuff coming to InterpreMed. If you're not already an InterpreMed member, you can join, and just make sure that if you want to be a part of the ethics club, that you make sure to sign up for one of the membership levels that includes Plus Memory Club. So yeah, you can join at interpremed.com, as Ncihc just posted in the chat. And so Ncihc, is there anything you wanted to add in the announcement?
Oh, yeah, I just wanted to add, because we have a combination of people who are already members and non-members, is that on InterpreMed, you don't only get the ethics club and the advanced note-taking club, but you also get a lot of practice material for medical interpreters. We have, like Kelly mentioned, all the note-taking exercises, but also vocabulary exercises, flashcard quizzes, side translation, simultaneous interpreting, consecutive interpreting, and also every month we choose a different topic. We have the study guides. So for example, last month was the oral exam. This month is the written exam, which is why we decided to announce the ethics club. Is all about ethics and standards of practice. So basically, as a member, you get everything that InterpreMed has to offer in terms to basically become very, very proficient at all. I will say yeah, almost all the interpretation skills that you need, almost all of them.
We're working on it. We'll add a whole bunch of extra stuff.
Yeah. Yeah.
I just wanted to add, as a member of the Interpremed site and an interpreter, it's helped me hugely with a lot of vocabulary, a lot of the dialogue, everything. It's really, and I looked around at all different kinds of sites. It was the best. I completely recommend it. I also do some teaching. I recommend it to my students. I think it's really good. I'm not a paid, I'm just a member.
Thank you, Jordana.
Thank you, Jordana.
Yeah, Jordana, this reminds me, we also have live meetings, like the Spanish club meets on Mondays, Wednesdays, and Fridays, and you practice with people from Peru, from Mexico, Dominican Republic, all different backgrounds, and that's always super exciting because we get to learn from each other, not from Interpremed, the materials Kelly and I translate, but also all the things that everyone brings to the table. And we have very strong Arabic and Spanish teams, but we are constantly expanding to Portuguese, French, Japanese, etc. So thank you, Jordana. That was nice.
That was very nice of you, Jordana.
It's true. You're welcome, guys.
So, do you think we might be done with, do we have something like that for Cantonese? Do we have any Cantonese interpreters who are members of the site?
No, not yet. I mean, we may have some few Cantonese interpreters. We have a language neutral group in which we add everyone who does not have a partner or a group to practice with. And basically, the more people join, the more groups we create. So for example, we started with Spanish, but then a lot of Arabs joined, Arabic speakers, and then we created the Arabic team. And then we got Japanese and we opened the Japanese one. So if the same happens with the Cantonese team, if you tell one of your friends, hey, join me, you only need 2 people committed to, like you and another person committed to meet at a certain time, and we will enable you the materials to practice together. Okay. Thank you, Faith.
So I wanted to make sure, does anyone else have any questions, whether with regards to the presentation about Interpremed? We are here to answer your questions.
Yep.
Comments, concerns? All righty. Well, Ncihc, thank you so much for staying during this whole thing. I know you weren't planning to. I must have been very engaging for you to stay the whole time.
It was great, Kelly. You did, like, you overdid it. It was super interesting. You had a lot of activities. I learned a lot. I liked it, and I really want to see all the other standards of practice and codes of ethics to see how you develop them. I think
Yeah.
all to
and sorry, we always do this.
Okay, I have something to say, but it's like a very like a final message just before we leave. So
yeah, go ahead.
Okay, so I have created this form. It is a feedback form that I would like you to fill out. If you know, just to let us know your comments, how do you feel, any feedback, positive, negative. And here is the form, and you are able to fill it out. And also feel free to add Kelly and I on LinkedIn, Facebook, search for Interpremed. If you search my name on LinkedIn and you send me a request, I will accept you right away. It's always super cool to do that. And yeah, that was basically it. Follow us on social media. We do a lot of these things.
Yeah, and I'll even add on my website, I have a page in case anyone's interested, because my social media stuff isn't really up on Interpremed. We're still working on our About Us page, but that's, oh my goodness, I sent as a direct message to Yana. So all of my social media is on this page, kghinterpretation.com/subscribe. And I did just want to say to Interpremed members or anyone who may be joining Interpremed right now, if you go to practice material, actually, I will. Oopsie. Now, the only thing is it's going to show the top admin bar, but that's okay. I'm going to go ahead and share my screen and let everyone see what is in the ethics and standards of practice, not ethics and standards of practice. Well, this is the ethics and standards of practice course, but if we go to practice material, now you'll see the ethics club is there. So in ethics club, I actually posted a bunch of the stuff today. This is what I was like working really hard on today. I'm going to be posting the recording to this here. We're going to have the quiz, Let's Talk Ethics, Confidentiality for Medical Interpreters. So we actually have a quiz on this entire presentation. I have a written version of everything that we have discussed. So I understand that video might not be the best format for everyone to compare and contrast. So everything is written. And then we have a multiple choice quiz. It's 5 questions, but it's actually ethical scenarios. And I give some detailed explanations, kind of giving you feedback on your responses. So you can kind of know, okay, why is this the correct answer? Why is this the incorrect answer? Or why is this the best answer? I like that better than correct or incorrect. So we already have content in the ethics club and it will be added to. I'm planning on adding some extra stuff here shortly. I will stop that share.
Yeah, so it's been like about 2 hours, so it's okay if we leave now. I'm going to have some dinner, and this was great, everyone. Thank you. I like to see new faces.
Thank you all so much. You all have been so great and so interactive, and oh, I love it.
Yes, this was a great group. Keep it up. Okay, so I guess I'm going to stop the recording now, and goodbye, everyone. Take care.